Let me see here. See if I can set it up properly. Edit. Details. I think I set it up right. Testing, testing. Testing, testing, testing. Is this working or not? Let me see. I wanted to actually do something. So share. Oh, look, it's Asha again. So good to see you, Asha. So it is working. Let me see if I can share this. Copy. Discord. Paste. I'm gonna do two things while I'm setting this up. Now I'm gonna go on Reddit. And on Reddit, I'm gonna go to new to EMS. It's my favorite Reddit channel. Create post, image, drop an image. Where's my tutoring image? Next hour, stop by if you'd like to ask any questions. And then here's the link. Oops, oops. Did it work? Oh, there's the Losers Club. So good to see you, Losers Club. So good to see ya. Post. Oh, wait. Blair, NREMT. Educational. That's a good one. Post. Post. And then comment. Edit. Sorry guys, I need to edit this real quick. Come and join live. I'm doing this really quick, guys. It'll just take a moment. Comment. And then if you click it, it's up. Okay. Do you guys have any questions regarding EMS? And usually I have my headphones in to make sure that my audio is good, but I'm pretty sure it's good. Let's see. Does anyone have any questions regarding EMS? Anything at all? Anatomy and physiology, that's a really good one. I think we'll start with that. We've only got about an hour or so, but I think it'll be fun. So, we have a question regarding A and P. That's a great question. Let me open this up on my phone real quick just to make sure we're solid on everything, which I think we are. And then we'll start. Oh, come on, come on. Yes, it sounds good, and the text is popping up. I'm mastering this, guys. This is good. Okay, so you're asking about anatomy and physiology. That's a great question. Do you mean more so like the heart? We can go over the heart first if you'd like. The heart is a very cool thing to go over, and it's really important in regards to A&P. Unless you want to ask about something else, we can go over that too. But the way I like to see the heart, for instance, so I'm just going to kind of go into the heart. More practice about NREMT practice questions. We can go over that as well. I agree. Well, I have a couple practice questions that we're going to hit up near the end of it. But yes, I think that'll be fun. But I'm going to kind of tackle this more so as A&P. So I'm going to go over the heart real quick, and then I'll go more into that afterwards. So like right here, we have the RA, the right atrium, the left atrium, the right ventricle, and the left ventricle. And I think this kind of answers some of your questions, Asha, but if it doesn't, let me know, and then I can definitely adjust. But this is how I like to look at the heart. So let me pull up a heart image. Right here. This is a good image. And I'll post this on here. Beautiful. Can I minimize this? I can. So sometimes people will look at the heart and they'll look at it in this aspect. I would highly recommend looking at it as a box because I find that it makes it very easy. I'm going to go ahead and put a brush here and I'll make it kind of big. So if we're looking at the heart first, we know that we have the right atrium, right? Which is this area right here. And the right atrium gets fed deoxygenated blood from the superior or the inferior vena cava and the superior vena cava, right? And deoxygenated blood will dump into the right atrium. So that's why it's blue. Then from there, we go from the right atrium and we go through the tricuspid valve. So we think of it as like a try before you buy. And it fills deoxygenated blood to the right ventricle. Okay. So we fill deoxygenated blood to the right ventricle. Then from there, the deoxygenated blood travels towards the lungs. So I'm going to just draw like a kind of crappy image of lungs here. And it goes through the pulmonary artery because arteries go away from the heart. And we feed deoxygenated blood from the pulmonary arteries to the lungs, right? So you kind of imagine it's going towards the lungs. And then oxygenated blood is traveling towards the left atrium. So then we'll just kind of do a full circle here. And then we'll just kind of merge them together. It's fine. Then we have the pulmonary veins, which feed oxygenated blood to the left atrium. We'll go from the left atrium now that has oxygenated blood. And then once I draw this out, we're going to go over like a concept or two. Then we have the bicuspid valve, like so. And from the bicuspid valve, we will push the blood to the left ventricle. Ooh, it looks kind of bad. It's okay. And then from the left ventricle, we will push blood towards the aorta. So the aorta kind of like, it'll branch out like so. And usually you'll have 3 different little grooves here. Right, so we have 1, 2, 3. And then it'll go down towards the descending aorta. Okay. And then from the descending aorta, we feed arteries, things like that. It goes and it performs capillary perfusion to different muscular tissue. And then it goes all the way back, full circle, to the veins. So it'll perfuse with tissue. So it'll go from arteries to arterioles to tissue. Oops. No, I want this to be black. It'll go to tissue perfusion. And we will oxygenate muscular tissue. And then release CO2. I'll just write it as 2 like that. That's fine. And then, that's kind of janky though, right? Let me fix this. I need to steal a 2 here. And then the muscular tissue will release CO2 or deoxygenated blood. And then the deoxygenated blood will travel back towards the veins. So if I get a brush here, it'll go like so, back towards the inferior and superior vena cava. So like if I decide to label these, I can go here. I'm going to draw some lines. That is the inferior vena cava. And I'm going to make this like a 16. That'll be nice. Inferior vena cava. We have the superior vena cava right about here. So I'll write that. Superior vena cava. Ooh, no, 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 no. Let me draw that again. Superior vena cava. We have the pulmonary arteries, the pulmonary veins, the pulmonary arteries right here. We have the pulmonary veins. We have the bicuspid valve and the tricuspid valve, so like right here. We can label that, even though it's kind of far away, as the bicuspid valve. And then over here, we have the tricuspid valve, also known as the mitral valve. So tricuspid valve or the mitral valve. So that's in regards more or less towards like the heart and kind of what's going on. And I can draw some more lines here. That's really what you need to know as far as like the National Registry in regards to the pathophysiology of the heart. How's nursing school going? Also, your videos helped me a lot when I was studying for my NREMT. I passed on my first try and landed my first 911 job. Congratulations, Lee. Or congratulations, Lee. That's what I like to hear. Nursing school is very fun. I just passed a pharmacology test. I didn't really study for it, but I have a really good grasp of pharmacology just in general. So I made like a 92. I could have done better if I did review though. But besides that, I'm very happy. Thank you, Asha. I really enjoyed it. I did some tutoring also where I went to go see a tutor for an hour, and all the tutors are phenomenal at the college that I'm at right now. So I really appreciated that. You have an exam for the NREMT on October? Good, good. I'm sorry you got late. Sure, Gabriel, don't worry about it. We'll touch up on this, but basically what I was showing is that I like to look at the heart. Is there like a way I can make my cursor bigger? I really can't. I'll do this. I like to visualize the heart as boxes versus the overall imagery like on the top right here. Uh, it's good to know the top right imagery, but it's really easy to understand the heart if we just look at it as boxes. So like we have like our right atrium here. So our right atrium gets fed with the superior vena cava and the inferior vena cava with deoxygenated blood. That's why I colored it blue. From the superior and inferior vena cava, the deoxygenated blood goes to the right atrium. The right atrium pushes blood through the bicuspid valve to the right ventricle, right here. And then the right ventricle will push blood, or deoxygenated blood, to the lungs via the pulmonary arteries. Oh, I guess I screwed up my drawing then, huh? Uh, Converse, congratulations, good job. Sounds like you did really good. I completely messed up the wording here, so I need to fix this. Can I make this eraser bigger? These are the pulmonary arteries. I even got confused myself because of the color scheme. Whoops, whoops, whoops. And then this is incorrect too. But basically, deoxygenated blood goes from the pulmonary arteries from the right ventricle to the lungs. And then, let me write this again. These are the pulmonary veins. These are the pulmonary arteries. Gas exchange occurs in the lungs with the alveoli. It releases CO2 and then it obtains oxygen through the molecules of heme. And then, excuse me, the pulmonary veins bring oxygenated blood to the left atrium, which pushes blood to the left ventricle, and that goes through the tricuspid valve, also known as the mitral valve. If we're looking at test questions, guys, the pulmonary veins, the pulmonary arteries are great test questions. What's another good test question? Is understanding where the bicuspid valve is, understanding where the tricuspid valve is, and the other name for it. Those are like the real ticket items throughout all of these here. The left atrium then feeds oxygenated blood through the tricuspid valve or the mitral valve to the left ventricle. And then the left ventricle pushes blood to the aorta, which has 3 different tubes here. It goes to the descending aorta. It leads to tissue perfusion, and then the whole process repeats itself. So that's pretty much what we went over, Gabriel. Let's see. Whenever I got my study time, I've seen so many EMT videos and it helps me a lot. Thank you. That's great to know. Asha, make sure you study operations and all kinds of shocks. Yes, that's very important. And we can go over operations after this. I'm cool with that. Um, but this is more so for like the pathophysiology for the heart. So, what would I take away from this, guys? If I had imagery like this, I would really only learn a couple things. I would know where the pulmonary or what the pulmonary artery and vein does because it's a little bit trickier compared to our regular arteries and veins. And I would know the bicuspid valve, the tricuspid valve, also known as the mitral valve. Okay, that's all I would know, guys. And you should be fine. A really great saying for the bicuspid valve and the tricuspid valve is try before you buy. Oh, no, no. Oh, did I mess this up then? Hold on. Whoa, 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 whoa. Where's the bicuspid valve? I might have flipped these two over. The bicuspid valve. Okay, try before you buy. I did flip the two. Good thing I knew the saying, right? Let's see. We're gonna fix this real quick. We're gonna delete this. We're gonna delete this. One more time, guys. One more edit. This is going to be the tricuspid valve. This is the bicuspid valve. Okay. So let's erase this too then. No, 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 no. Let me delete this real quick. This will go away here. This will go away here and here. And then in even smaller text, I will put the tricuspid. Let's make it a 14. And then this will be the bicuspid valve. That's a lot better. Sorry about the confusion on that. But I would remember these things. I think you'll be fine. Right here. Okay. It'll make things very easy for you. A great saying, again, is try before you buy. Try before you buy. Tricuspid valve. Bicuspid valve. Parentheses, mitral valve. That'll carry you guys. If we look more so at what the actual roles of the heart is, the heart is like a two-pump system. So basically, it acts as the whenever the heart collapses, especially for the ventricles, when it reopens up, it kind of fills up a lot with blood, about like 80%. The other 20% is the atriums that are filled up. It'll push blood into the ventricles. And so the atrium's only job is to feed blood into the ventricles. The ventricles' jobs are either to push blood, deoxygenated ones, to the lungs, or push blood throughout our whole body as the left ventricle. Since the left ventricle has to push so hard, there's usually a lot of muscular tissue all around this general region. And so people that take like testosterone, things like that, this muscular tissue starts to like build up and it can cause cardiomegaly, which is a big issue because it displaces a lot of organs later on. But I hope that kind of answers a little bit, at least for some pathophysiology for the heart. Let's see, what other questions? Let's see. Did it pass first time? Fantastic. Make sure you study. Okay, we have operations here. So this is a really good imagery of like kind of what's going on with the heart. If I look at operations, what do we need to know about operations? Need to know about EMS operations, right? What are some big ticket items? What are some things I would know? I would know like the triage symbol, right? So I would know, let's see, the hot zone, the cold zone, warm zone, cold zone. So I would know more or less this imagery for like EMS. Let me see if I can find a good one. This is a pretty okay imagery, but there's something else that we should see too. Okay, so if you're in a hazardous operation, You'll have to deal with hot zones, cold zones, and warm zones. I wanted this imagery because it actually shows like the decontamination corridor. But more or less, you just want to know whenever it comes to the hot zone, the warm zone, and the cold zone, where does EMS go, right? So decontamination occurs in the warm zone right here. Only techs and everything will go into the hot zone, so you should never enter the hot zone unless you're certified to do so and trained. The cold zone is where EMS operations will occur in a hazardous material incident or just a hazard incident in general. So knowing that can help you a lot. What's another thing for EMS operations? That's an easy one. So EMS operations, what are we thinking here? We're thinking things like know about intersection, know that EMS personnel die at intersections, right? That's a very big one. Know uphill, upwind, right? It's a very common saying, but basically, if you're in a hazardous, I'm gonna go ahead and delete this, guys. Let me go ahead and clear this out. But if you are in a hazardous area, the best spot to park is uphill and upwind, so that if this is the hazard here, and we'll just kind of color it red or something, we want to park the ambulance. Oops, let me make it kind of like blue, maybe. We want to park the ambulance, and I'll just type in text here, ambulance. Uphill from the incident and then upwind. What does that mean? That means the wind is going to be blowing in this direction and that we are uphill. Oops. Or far away from the incident. So that way, in case, let's say it's a chemical reaction and some of the off gases are occurring that may be detrimental to our health, we don't want to breathe them in, so we want the wind to push it away from us. We want to be uphill. Now, we can't always do that in a normal setting, but in a textbook setting, if we see that option, we're going to pick uphill, upwind, right, for EMS operations. What's another big thing for EMS operations? Okay, knowing the different blast zones. Knowing the different blast zones. What do I mean by this? We have like our primary, secondary, tertiary, and quaternary. Tertiary, quaternary. Excuse me. And let's see if I can find it here. So this isn't the best imagery. I just copied this image here. I found this image from Health Jade. But basically, if we are in any incident where we're concerned about an explosion, the first thing that we have to worry about is the primary blast wave, or the the blast wave that occurs from a explosion. The second thing that we have to worry about is the fragments that may occur from the explosive itself, as well as anything or any shrapnel, any objects that are in our way between us and the explosion can fly out and potentially pierce our skin or cause blunt damage. We have the tertiary blast injury where our body gets propelled, and then let's say we hit a wall or something like that. And then the quaternary blast injury is like burns that can occur. So having just an idea that an explosion is a multi-injury type occurrence, where basically we don't just get injured from the blast itself, but there's a lot of different factors that go into explosives, can help you a lot. And we don't just deal with this whenever it comes to like terrifying incidences. We also deal with this a lot during firefighting. Like let's say if we're dealing with like a propane tank and then it explodes, you need to have an idea of all these different systems that may be into effect, because the primary blast injury, for instance, would affect like hollow organs, and then the secondary blast injury could cause penetrating trauma, and the tertiary blast injury can cause like a spinal injury, and then the quaternary one, now we're thinking that their skin may be damaged or burned, and now they may suffer from hypothermia or some type of like fluid loss in general. So we really want to do a detailed assessment on these kind of things. I hope that answers some of your questions regarding EMS operations, but that's a general view of it. There's a lot more that we can go into detail, but that should kind of help. Let's see. Any other questions? If not, I'm going to go towards like the body and talk about a couple things. But we have like, let's say the anatomical plane, right? So if we pull up the anatomical plane, let's see a good one here. This is a pretty good image. And if I pull this up to right here, a big thing is knowing what's considered proximal, what's considered lateral, right? So if we're looking at a person, and let's say we're looking at our thumb, right? We would ask ourselves, or not even what's proximal and what's distal, but that is an important thing, but also what's medial and what's lateral. So if we're looking at a person and they're standing upright, or if they're sitting down, which one is proximal and which one is medial? So I want you to look at your thumb right now. Look at your thumb right now. Tell me if it's medial or lateral. Medial being closer to the midline of the body. Lateral being further away from the body. And see if you can answer that. Okay, so you're saying lateral. So you're saying your thumb is lateral or further away from your body. Anybody else have any guesses? That's a good one, Asha. I want you to just look at your thumb and tell me, hey, is it medial? Is it lateral right now? Which one is it? And is there anything that needs to go with that? So I'll give you guys another moment, but Asha's got their answer locked in. And so, okay, we'll get into it. The thumb is always going to be lateral. So no matter how your hand placement is, like even if you have your hands like on a flat on your lap and your palms are down onto your thigh or whatever, it's still going to be lateral. Why is that the case? Because every time we look at a human body, we should imagine it in the anatomical plane. So the thumb is always going to be lateral no matter where you're at, because we need to, when we imagine a human body, we need to imagine it as the, and we can go into that, sir. We need to imagine somebody into, or as the anatomical plane. So the thumb is always lateral to the pinky because it's because regarding anatomical plane, it's always further away from the body. So it's very important to recognize it's always going to be lateral, because you should always imagine somebody standing straight up and then their hands out to the side like so. So Sears says, I have trouble with seat and size up. I know the mnemonics and everything, but I'm not sure exactly what comes in order to put the patient on, or when to put a patient on a stretcher. We can go into that in a moment, but that's a great question here. But just real quick, another thing is like what's considered proximal, what's considered distal. So proximal is closer to the midline of the body, or yeah, closer to the midline of the body. So I'll say like, for instance, your wrist is distal to your antecubital region, or like your elbow. Or vice versa, your antecubital region is proximal to your wrist in comparison to the two. Some texts can kind of really confuse that, but we'll just kind of leave it at that. Anyway, let's see. Seer asks, I have trouble with scene size up. They're familiar with the mnemonics. We can, Rexus, and we did kind of already go over a little bit of it, but we can go over more of it. Uh, Actually, I kind of know what you're talking about. We can take a look at that in a moment. But let's see. Sear says, I have trouble with scene size up. They're familiar with mnemonics. Oh, patient assessment. I mean, not scene size up and everything, but I'm not exactly sure what comes in order to. Okay. Oh, you're okay, Rex. Don't worry about it. Okay, so you're asking, you have trouble with patient assessment? Like in what order to go? Are you asking in regards to patient assessment, as in what order to go? Let me double check on that. EMS, scene size, PSI, scene is safe, LOC, ABCs, primary assessment, secondary assessment. There's probably some good imagery that I can pull up. Let's see if I can find something that's good here. Assess mechanism of injury. Okay, that's a pretty decent one. It's a pretty good one. Okay, let me see here. Like, what order do you go in? Okay, I see what you mean. So this is a pretty good imagery of what we can do. And I found this on Reddit. Okay. And so what we have here is, I'll kind of walk it through you a little bit, or with you a little bit. So we have like, and I see your question, Asha, we can get into that also. We have our scene size up, right? So on every scene, we always start with BSI, is my scene safe? We put on gloves, then we make sure our scene is safe, right? If it's not safe, we don't go into the scene. Next thing that we're gonna do is we're gonna do like our primary survey. So we're assessing like, hey, what do I see? What's going on? What's my level of consciousness for my patient, right? This for my patient. Are they ANO times 4? Can they answer person, person, place, time, and event? We'll ask, what's your name? Where are you at? What day is it? And do you know what happened? Okay. From there, we will do ABCs, and sometimes we'll do XABCs, just depending on the patient presentation, where we will do critical life bleeds. We'll do airway. We'll do breathing. And then we'll do circulation. Okay. We'll do our ABCs, managing our patient, blah, blah. We'll get some like of our sample questionnaires, right? So then we'll go through sample. We'll go through sample / OPQRST. So what is like sample? We have signs and symptoms. We'll ask about allergies. We'll ask about medications, past medical history, last oral intake, and then events that led up to this. For OPQRST, it's more so if somebody has any pain. We'll ask about onset, provocation, quality, radiation, severity, and then the time that this has occurred. And sometimes the time and the events kind of like line up together. Okay. From there, we can start to do like we'll do like a primary assessment where we're kind of focusing more so on the main issue. Like if they're complaining of like, let's say like left leg pain, then we'll kind of hone in on that. We can do like a secondary, more like detailed assessment, while also assessing vital signs, even though it's kind of displaced here. So we can check the patient's vitals while we're doing these questionnaires or these general questions here. So like at the same time, gather vitals with your partner. We will do a full detailed assessment. Normally we'll do that inside the back of the box. Full assessment in the back of the box. And then we will reassess our patient every 5 minutes if they're critical, every 15 minutes at max. And I'm talking more so about vital signs and things like that, if they are a stable patient. Okay. And that's more so kind of like the way we kind of run calls, or the way we should consider running calls. Of course, there are a lot of other questions we can ask besides just sample and OPQRST. This is just a good way to get kind of kick-started on it. So I hope that kind of answers some of your questions regarding patient assessment. You said, can we go over pathophysiology? Okay, that really depends on what you're asking Rex's for pathophysiology. And Sierra, I hope that answered your question, or if you have some other question, let me know regarding that. So, what do you mean by pathophysiology? Do you mean how medications work? Like, how do these medications work with this system? Because I can kind of go a little bit into that depending on what you mean, but it's a very broad term. You could also be talking about like what diseases are how they interact, but it is very broad. And also, while you're thinking about that, Rex's, Asha says, can you please summarize about oral exam EMT-B? Which order to start and where to stop if make mistakes or nervous? Any ideas? Okay. So I'll wait for Rex's to specify on what they mean by pathophysiology, but I can do like a literal drawing. So like, let's say this is you, okay? Asha, this is you. This is your preceptor. I'm going to give you as much visuals as I can, okay? Your preceptor will usually have like a paper, and they're going to be reading off a scenario, okay? And what I'd imagine they're going to do is they're going to say something like, I'll type it out. Okay. You have a 31-year-old male patient laying down on the floor. What should you do first? Okay. And if I was your preceptor, what would I expect you to say? And you know what? We can even put this in text right here. Okay. We'll say this is Asha's scenario. Okay, so Asha. Okay, you have questions about those? I'll write those down real quick. We'll try to touch up on that. But Rex's questions regarding pathophysiology. We'll go into that after this, Rex. I'll put this right here. Okay, right. So we do, what's the first thing that we're going to do if we are the student? We'll say, BSI, is my scene safe? While pretending to put on gloves, or actually put on gloves, right? Because BSI just means body substance isolation. Is my scene safe? Your preceptor will then say, your scene is safe. Now, you're going to simulate walking up to your patient because they are laying down on the floor, and immediately you will say, I'm looking for any pooling of blood while checking for airway, breathing, and circulation. I'll ask, does my patient have a pulse? Okay, then your preceptor will say, great job, your patient has a pulse and they're breathing. And let's say your patient, if they're supine, if they're laying on their stomach, we need to roll them over. If they aren't supine, then we need to ask if there was a witness. So then if I was a student, if I was a student, I would ask if somebody witnessed their fall. If no one did, then I would put them on a C-collar and a backboard. If it was a witnessed controlled fall with no trauma, I would not put them on a C-collar backboard. And that's my rationale behind that. And then from there, let's say they're breathing fine or they are breathing. And then the next thing I would do after we rotate them, if they're not already rotated, is I would say, okay, I'm going to have my partner assess for vitals while I look for pill bottles, for any clues regarding why my patient may be on the floor. I can get into that in a bit, Lee and Rexus. That's a great thought process for like questions. So I'm gonna have my partner assess for vitals while I look for pill bottles for any clues regarding why my patients may be on the floor. From there, I'm going to gather my vitals, and your preceptor is going to say, what vitals do you want? Okay? What vitals do you want? What vitals do we want on our patient? Okay, what vital signs are important for any patient? And then leave for your recommendation for pants. What would I do for EMS? Honestly, just like any pants are fine. You can do 511. They have pretty good tactical pants. You might also just be able to find like a local option that could work too. But 511 is a very popular brand. So like something like this. Right? You're just looking for pants with like kind of these pockets like on the side like so. Okay, so we have some vitals. Okay. But yeah, 511s are a pretty decent option. So we're looking for a blood pressure. We're looking for a heart rate. Okay. We're looking for an SpO2. Oops. I need the number 2 real quick. Let me find it somewhere. There's a number 2. My 2 is broken on my keyboard right now, guys. Okay. What else am I looking for? I'm looking for respiratory rate, a temperature, and I'm looking for a blood sugar. Okay. And then if I give you these, I'm going to ask you, okay, is this good or bad? And the way I learn it is 130 over 139 over less than 100 is normal. For the heart rate, how did I learn it? 60 to 100 beats per minute is normal. SpO2, 95 to 100% is normal. You need to know what's normal, because if they tell you what the vital signs are and you don't know how to interpret them, then what good is it, right? 12 to 20 breaths per minute. And figure out what your school wants you to learn it as, okay? This is just an example of vital signs. This isn't concrete. This is just what I teach students to make it easier for them. To 98.9 degrees Fahrenheit, and then a blood sugar of 70 to 120 is considered normal. Some schools will teach it as 80 to 120. Just figure out how your school wants to know it. Okay, so you have your vital signs. Now you can kind of clue in what's going on. Don't forget to assess pupils. Don't forget to assess the body. And literally, it can be something as simple as if you have a human body, and you can be like, I'm checking for decap BTLS. I'm checking for like bruising, lacerations, cuts on their arms, on their legs, on their face. Finger stick blood. Oh, sorry. For me, that means finger stick blood glucose. It's just because I used to work at a clinic. You could just memorize this as blood glucose. It's fine. Finger stick blood glucose. However you memorize that, honestly, Rex's, it's fine. I just learned it that way. Just because of how I used to work at a clinic for a while. But okay, don't forget to assess the pupils. Don't forget to assess the body for trauma, right? Because we can usually they're going to give you the answer. If you know what you're looking for, they don't try to make it hard. If you panic, don't worry. Just remember sample and OPQRST. Okay? if you can remember sample and OPQRST, that'll usually carry you through any oral examination. And that should piece it together more so what's going on. Learn your EMT-B medications. And then afterwards, decide the priority transport. Level 1 or level 3. We only do 1 or 3. We don't do anything else. Level 1 is non-critical. So we don't go lights and sirens. No lights or sirens, which normally that's what we do. Or level 3, like let's say if it's a stroke patient or something, we'll go critical. We'll use lights and sirens. Know when to ask for ALS intercept. And that should generally carry you as far as your EMT-B oral exam. I know you've been kind of worried about it for a bit, but honestly, there's really not much to it. Just knowing your basic vital signs helps a lot. Knowing your EMT-B medications helps a lot. And we have videos on that on the actual channel. I have like a whole like 20-something minute video that just goes over EMT-B medication. So feel free to check it out if you're curious. It goes over the indications, contraindications, and everything in between. Anyway, I hope that answers your question, Asha. Again, Lee, for your question, Lee, I would recommend 511 pants. However, navy blue pants are decent. Yeah, and it's I mean, Asha, I think you'll be fine with just that. I think you'll do a good job. Okay, now Rex's has kind of like a loaded question. He's asking more so about like anaerobic metabolism, sodium potassium pump failure. Oof, you got a tough question, Rex's. Okay, so anaerobic metabolism. Is that DKA? Let me check. DKA, anaerobic. Pretty sure that's DKA. Let's see. Or more so metabolic acidosis. Okay, that works. Okay, so Rex's. I'm gonna imagine you mean anaerobic metabolism, or what's it called? Not anaerobic metabolism. It's metabolic acidosis. Actually, you know what? Let's go over anaerobic metabolism. That's fine if that's what you're asking. For anaerobic metabolism, you're not going to perfuse normally. So like if you're working out, you may start to build up like lactic acid. Okay, that's whenever you're not obtaining enough oxygen, and so your muscular tissue starts to build up lactic acid. You start to stiffen up, and I mean, this question can be pretty complicated. You can go all the way into like the Krebs cycle and glycolysis, things like that. This is a very loaded question. Let's see. So you don't properly go through glycolysis. This is through a website called Kusabio. Oh, that's not right. Paste. Bad. Glycolysis, lactic acid. Show me that. Where basically like you're producing, I think it's when you're producing these NADHs versus going through the actual glycolysis system, because you're not interacting with oxygen properly. So that's if you have lactic acid formation versus the actual, come on man, give me a good image here. Glycolysis itself is so much more complicated. And you really don't need to know this as far as EMS is concerned, but it is good to know just generally, like if somebody isn't perfusing properly, they may have lactic acid formation where they're going to feel kind of groggy, kind of sleepy. So I'll ask you this instead. This is a very good question. What patients may be going through a buildup of lactic acid? So you guys got any guesses? And let me see if I can increase the size. Or like anaerobic metabolism. which means metabolism without oxygen. So what are some instances where we can expect to see maybe like lactic acid formation? And I'll give you guys to think about it. When are my patients not perfusing properly? And I'll give you a moment, and then afterwards I'm going to kind of go through it. But if you meant metabolic acidosis, by the way, the common answer for that is just diabetic ketoacidosis. Low of oxygen, exactly. So low of oxygen. So when is a patient low of oxygen? Some examples are cardiac arrest calls, right? Seizure calls, right? And then another kind of niche answer choice is like apneic patient or patients who have sleep apnea. Okay, so cardiac arrest calls, we can expect them to build up lactic acid. If somebody doesn't perfuse for like 2 hours and they've been like dead for like 2+ hours, we may see an instance of rigor mortis where somebody actually has like stiff arms and legs. Apnea means lack of breathing or not breathing. And so the sleep apnea is kind of more niche than these other two. But for cardiac arrest calls, we can expect somebody to not be perfusing properly, so they start to build up lactic acid. If it's been like 2+ hours, we can start to see to where their arms are stiff, their legs are stiff, and that's like an easier way of us saying like, hey, this patient's been dead for hours, not minutes, right? Uh, we can see patients who have seizure calls. They go through episodes where they're not breathing properly, and that's why we try to stop the seizure as a paramedic. We'll administer a sedative like Versed or Valium. We'll administer mag sulfate if it's a pregnant patient that's seizing, because if they're not perfusing, then their baby isn't getting oxygen just like the mom, so they'll both end up dying. But that's more paramedic. For sleep apnea, this is again kind of niche. You'll see that patients, let's go over sleep apnea. For sleep apnea, it's generally with patients who snore at night. They are overweight. They can sleep pretty much anywhere at any time. They're usually the kind of patients who will be watching a movie and halfway through they'll like fall asleep or things like that, and then they're overweight, and they will wake up at night because they're snoring so much and they're not breathing properly, and they end up actually like choking. So they'll wake up at night gasping for air. If this is the case, then what's going on? Depending on how obese the patient is, let me see if I can find a fat neck. Sleep apneic patient. Let's see here. This is a good image from Neurology Consultants of Arizona. I like this image a lot. Basically, what's going on with these patients is their body isn't perfusing properly because they're getting shut off from oxygen every now and then. It causes lactic acid buildup. It causes them to become more groggy at night or in the morning, because compared to a sleep apneic patient and yourself, if you get 8 hours of sleep and they get 8 hours of sleep, they get the equivalent of 4 hours of sleep compared to our 8 hours of sleep, because they're not perfusing properly because they're not receiving enough oxygen. And what happens to these patients is they're not able to metabolize properly, so they start to get more weight gain. And as they get more weight gain, right here, see if I can kind of circle it. Oh, it's a horrible circle. Maybe I can highlight it. No, here, that's a pretty good one. Their fat on their neck, oh, okay, it just kind of like disappeared. The fat on their neck is compressing against their trachea and their esophagus, and it's kind of preventing them from being able to pass air to their trachea, and is causing them to get fatter. And as they get fatter, it compresses and compresses, and they get fatter and fatter, and it causes this cascading issue. So what can these patients do? They can get something like a sleep study done to see if they actually do have sleep apnea, and if that's the case, maybe they'll sleep with a CPAP device, or they'll sleep with something like this. This is from MIT News. So you'll see patients start to sleep with something like this, and it helps them perfuse at nighttime regularly. It helps them start to utilize, like, it helps them perfuse to the muscle tissue. You're going to see they're going to start to feel more energetic. They're potentially going to start losing weight because now their body's able to obtain that oxygen that they need to properly metabolize whatever's going on in their system. So it's an interesting phenomenon. I know you had some other questions on pathophysiology, like the pleural space chemoreceptors. That's tricky. What's a little tidbit I can give you for the pleural space CPR calls? I'm gonna do this and then go over some practice questions and then probably stop there because I gotta pick up my daughter at 5. But this is from Vitali Partners. I love to keep going. I just also have to pick up my baby. But maybe this will give you some things to think about regarding pathophysiology. And also, let's see if I can find a definition for apnea for you. So it's a temporary pause in breathing, and most common in sleep apnea. Good, good. It's just giving you something to think about, right? But there's the term for apnea. So whenever we see the root word nia, or words that end in pnea, we think breathing. We think of breathing, right? So if we see tachypnea, fast breathing. Bradypnea, we think of slow breathing. Okay. We see dyspnea. I believe that means abnormal breathing. Sometimes you can regard it as like painful breathing. We see apnea, lack of breathing, or we would just say no breathing, the cessation of breathing. Okay, so they all end in the pnea. So something to think about. Let's say you are a bystander and you're walking around at a grocery store. So I'm just going to type in an imagery of grocery store. We'll paint the scene this way, right? So let's say we are at this grocery store here. Can I find a good one? I want like a side view, not really a... This is from NBC News. And what I'll do... This is where we're at. And then we see this lady doing CPR on this person who just initially collapsed. Okay? And let's say you're the first responder. You show up, you don't have any of your equipment on you. And we see a downed patient who needs CPR, right? Are you going to breathe for this patient? Let's say if it's a stranger. If we see a downed person and we don't have our equipment, we start CPR while someone gets an AD. Are you going to breathe for this patient? Okay, Gabriel says no. He says negative. What do you guys think? In the movies, they do this a lot. Rexus says no. And personally, I agree. We're not doing that. There's an interesting phenomenon where halfway through, it's called like the void space right here. Ooh, let me see if I can get the paintbrush. Somewhere between the lungs and the actual like laryngeal space, there is about 500 cc's of air, so, or like 1,000 cc's of like like basically dead air or stagnant air. So as long as you're performing adequate compressions, that oxygen is still able to interact somewhat with the alveoli in the lungs. And so as long as you're performing adequate chest compressions, you're still helping perfuse the patient. Exactly. It can still pump blood to the heart and brain and to the lungs, and it can slowly start to help reperfuse. Yeah. So what would I do? I would do active compressions, see if we can throw an AED on a patient because they're still technically able to perfuse with that void space oxygen for a little bit. At the same time, you don't know what the patient may be carrying. So I would never put my lips on a patient's mouth. If they had like a family member, like a spouse that wanted to breathe for them, that's fantastic. That would be a great role for them. If you see a bystander and they already started initiating it, you know what? That's fine. If I don't have my equipment and they want to breathe for the patient, that's up to them. Am I going to do it? No. I'm not going to take something while trying to save somebody and then end up carrying it to my family members. But just know that there's like this weird residual volume, like void space area right here that contains about 500 cc's to 1,000 cc's of air that we can still technically utilize from just applying direct compressions. Let me see if I can see it. Residual volume of air in lungs. Not interested. Go away. Let's see. CPR call. Let's see. Oxygen and ventilation during cardiac arrest, circulatory, blah, blah. Basically, there's residual volume in the lungs that can be utilized for a little bit. Can we use a pocket mask? Yes, you can. If you carry a pocket mask on you, then you can definitely consider using that. I just don't keep one on me. And so what do I do always keep on me? My two arms. And I keep my phone on me to call 911. And I have my voice to ask for an AED. Somebody has a pocket mask, or if you do and you want to use it, this is a perfect instance to use it. But don't beat yourself up if you don't use it. You just doing direct compressions is already so big. But I hope that answered somewhat some of your A&P questions. I know that they do like, I think it's like beta 2. You think of the lungs because it's two or like two lungs. Alpha 1, we think of the heart. But there's like a weird rule on it, Rexes, that it's going to take me a bit of, let me see if I can find out. What receptors work in the lungs? Beta and alpha. So the beta 2 receptors work in the lungs. And then let's see. And the heart uses beta 1 receptors. They also use alpha 1 and alpha 2. So just a little bit of food for thought, but honestly, I need to brush up on my alpha and beta receptors. I wanted to kind of end this. I know it's only like an hour long. Just going over some practice questions because I had a lot of fun with it last time. And so we're going to do a little blitz. This is on amateurmedicine.com. So if you're looking for a test prep, this is part of the study bundle that you can utilize. If I can click here. But you guys will get to see a little free view of it. So like the bundle, it includes a vital signs portion, a master of the EMT-B section, a GCS APGAR section, rule of nines, and then the study guide. It's a really good program. So if you're looking to study for the EMT-B, I'd highly recommend it. We're going to blitz through a little bit of vital signs in this portion. Okay, so this is at amateurmedicine.com. I'd recommend it for anyone studying the NREMT-B. Okay, so the whole portion or reasoning behind the vital signs portion is to just quickly get you to blitz through mastering your vital signs. So I want you to text good or message good or bad whenever we're looking at heart rates. Okay, and so what do I mean by this? If it's good, it's between 60 to 100 beats per minute. If it's bad, it's anything in between. So if we go over some practice questions, we'll give it a try. Is this good or bad? 36 beats per minute. What do you guys think? And this is meant to teach you vital signs in like an hour. Bad. I agree. Rexus says bad. You're correct. Asha says bad. You're correct. Next one. We'll try to be quick, guys, real quick. 72 beats per minute. Is it good or bad? For respirations, we're moving towards 12 to 20. You say good above 60, you say bad. Okay, so we're doing a heart rate. Asha, you're thinking of respirations. This is the heart rate. So 72, it's good. So that was good. 156 beats per minute, is that good or bad? Oh, that's okay, Asha. Where the whole point is we're talking about this so we can practice and learn together, right? So is 156 beats per minute, is that good or bad? Bad. We have a bad here. Anyone else? And why don't I make it more complicated than good or bad? I want to make this, I made this portion of like practicing for the NREMT specifically so that you can complete it quick, right? So that way you can memorize it. You guys are correct. It's bad. Let's do two more. 64 beats per minute. Is it good or bad? So that way you can just practice, run in, practice as much as you want, and learn about it. Yes, it is really good if you're practicing. You say good, good, good. Yeah, technically, Rex, that is the case. Like if you're trying to get your heart rate as high as possible. No, 64 beats per minute is actually going to be considered good, since it's between 60 to 100 beats per minute. But this is more so for recognition for the National Registry. We'll do one more. 92 beats per minute. Is it good or bad? You say good. Anyone else? Good, good. Oh, Gerardo says good. Good to see you, Gerardo. Good, good, good. I agree. That's good. No, no, 92 beats per minute is good. Why are these good? For the heart rate, we want it to be between 60 to 100 beats per minute. See, so that's why I have the reference range at the beginning. And that's why I have you practice these vital signs, because sometimes common sense will get in our way a little bit and we'll say, their heart rate's at 98 beats per minute. That's kind of bad. No, it's not. You have your reference range and then that's it. Who are you to determine what's considered a little bit high or low? How is it high if it's less than 100 beats per minute? So yeah, that's the whole rationale behind it, Rexes, is I want you to get to the point where you can quickly look through a question and be like, that heart rate's good, that blood pressure is good, that SpO2 is good, respiratory rate's good, let's move forward. Right? So that's the rationale behind it. We'll do like 2 SpO2 questions. So for the SpO2, we're going to go between 95 to 100%. That's what we're going to consider in our normal range. So is 100% good or bad? And then there's like all this text and stuff that's hidden away that goes over a whole bunch of different things for vital signs, but I'm kind of leaving that part hidden. You say good, 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 bad. So Gerardo, sometimes text will teach you 95 to 99% is normal. Some text will teach you 95 to 100% is normal. Some text will teach you 94 to 100% is normal. Sometimes some text will teach you 94 to 99%. Okay, I understand why you would say it's bad, Gerardo, if you're referencing that. But to me, it doesn't make any sense, because if you have a patient who's sitting at 100%, what are you going to do? Are you going to tell them to hold their breath for like a moment to get it down to 99%? No, this is perfectly acceptable. So if I see somebody sitting at 100%, I just say it's good and move on. So we're going to use this range right here, 95 to 100%. But I hope that makes sense to you. Sometimes we got kind of get a little lost in this in the sauce, right? So now we have somebody sitting at 91%. Is that good or bad? No, it can't go above 100. And no, it would not, Gerardo. 100% is just generally good. On room air is good. We wouldn't worry about it. But good question. It can't go above 100 because it's a percent. So 100%. That's like the max. But I hope that kind of answers some of it, Gerardo. It's so 91%. If our range is between 95 to 100%, I would call that bad because it's not between 95 to 100%. For a patient like this, what would I consider a nasal cannula at like 2 liters per minute, 3 liters per minute? That would probably work unless they have COPD. Then I'm going to keep them at 91% if that's their norm. Now 93%, is that good or bad? Which one do you guys think? Bad? Good? Now remember, Asha, the normal range is between 95 to 100%. That's what we're using, right? So, between 95 to 100. I agree, Rexus. A nasal cannula at 2 will do wonders for this patient. Unless you say bad? Okay, I agree. It's bad. The only time I would differentiate it is if, like, let's say I also wrote that the respirations were at a 10. Then what would I do? I would use a bag valve mask, right, over a nasal cannula. An SpO2 at 10%, is that good or bad? PVM, right? What would I honestly do if I had a patient like this and I was checking their SpO2? If I saw, and I've never seen this before, an SpO2 at 10%, I would look at their fingers. I would say, like, hey, is this on properly? And if not, I would readjust it, put it on a different finger on a different hand, and then kind of go from there. Maybe I'm checking blood pressure on this arm and it's squeezing it, so I need to swap to another one. Yeah, this is, you cannot sustain life with an SpO2 at this range. It's bad. So, we'll leave it at this, guys. I do have to pick up my daughter, but I just wanted to do a quick stream just for fun. You can find these YouTube VODs on cold fingers can affect it, exactly. And also a patient who is experiencing, what is it called? Carbon monoxide poisoning can actually have like a straight 100% long term. So we want to visualize our patient, but also 100% can be considered completely normal too. These really do help, of course. Well, thanks for stopping by, Gabriel. I really appreciate everyone who stopped by today. Rex's, Ash's, so good to see you. I'm trying to make this a daily thing. I know I don't really announce it too well, but I do try to give somewhat of a heads up in Discord. Here's a link to it if you're interested in joining it. But I do try to keep my note, or if you keep your notifications on, you'll be able to visualize it. Yeah. And if you have more questions about EMS, just let me know. If you're looking for a test prep for what's it called? amateurmedicine.com. If you're looking for a test prep for the EMT-B, I mean, this is literally the test prep, right? So like somewhat of a visualization of it, but there's a lot that goes into it. And if you have any questions in between, let me know. But we're probably going to do a pretty long stream tomorrow, so I'm really excited. But I'll give you guys more heads up, probably like 15 minutes before I start it. Thanks for stopping by, though, guys. I really appreciate your time. See ya. On the channel, on live videos. Bye bye. Bye bye. Goodbye. Goodbye.